Okay, guys, we got 1 more minute to go, and we have 3 of you missing. So I know Dr. Blakemore also has the link, so you might want to make sure you join the lecture. And I'm going to be starting in 1 minute. Okay, it's 1 o'clock. So today we're going to be talking about urological disorder and clinical toxicology. When it comes down to urological disorder, we are talking about two main conditions, which is erectile dysfunction and benign prostatic hyperplasia. So those are the two conditions we'll be talking about and their treatment. And clinical toxicology, we'll talk about all the drug overdose. Some of that we have covered earlier, like talking about acetaminophen toxicity. We'll go on and cover in more details today. And then you have other commonly ingested drugs like metal ions in terms of lead, iron. Iron is a part of a lot of supplements. So there is an accidental overdose happens with iron a lot. So we'll talk about that and cyanide poisoning as well. So that's the lecture for today. Hang on. Why my slides are not moving now? Okay, there we go. So learning objectives, as always, I help you guide through the content of the lecture and what is important and what is relevant for you to focus and remember. So these are pretty much covers both of those topics of the lecture. So the drugs which we're going to cover today is pretty much listed on your left side. The first 5 are listed for the treatment of erectile dysfunction, whereas the bottom all 3 classes are actually prescribed for the treatment of benign prostatic hyperplasia. And if you notice on the top 5, the bottom 4 of that actually all ends in FIL, F-I-L. So that tells you that they all belong to the same class. Whereas the first one, it ends with DIL, D-I-L. So that an indication that's from a different class. So when we talk about the drug treatment, what we are trying to do here, and this image down here actually talks about what happens in the process of erection. It starts with the production of nitric oxide and goes all the way increasing blood flow, and that increasing the blood flow that mediates this process. So for whatever reason, if this process is not working,
I mean, what are they going to do?
And, excuse me, someone said something? Is someone asking a question? Hello?
I think someone just left their microphone on accident.
Turn off your microphones.
No questions.
Is someone left the microphone on for any, by mistake?
Yeah, there's no questions.
Okay, cool. So we're talking about drug treatment. So the underlying process involves production of nitric oxide that goes on, and we'll talk about that when it comes down to mechanism of action. And it ends up result in increasing blood flow, and that what facilitates the process of erection. If something goes on, and the next slide we'll touch upon a little bit. I'm not a pathologist. I'm not going to talk about the pathology or physiology of that. What I'm trying to do here is to tell you what exactly these drugs are intended to do. They all are, in one way or other, going to increase the blood flow by causing relaxation of smooth muscle cells to facilitate the process of erection. So that's about the first 5 drugs here. And then comes down for all the BPH, we'll talk about these different drugs under different classes like alpha blocker and 5-alpha reductase inhibitor. There are others also in this class. This is straight from your textbook. Okay, again, my slide is, okay, moving. So this is what I was referring to. What are the underlying conditions? If you're on the left side, if you look at that, and this is, by the way, straight from the UpToDate, and you can just search for that on UpToDate and you find all these information there as well. So what I have here is just to give you an idea, there are different reasons that could interfere with the process of increasing blood flow. And that could be vascular, and that include your cardiovascular diseases, hypertension, diabetes, and others. Or it could be neurologic, spinal cord injury, brain injury, Parkinson's. It could have a problem with the local factors as listed here, or hormonal, hypogonadism, or your hyper and hypercorticosolism, or you have a drug-induced condition that interfere with the process that include antihypertensive, antidepressant. By the way, SSRIs are known for that. And that's one of the condition people don't take SSRIs for too long. And patient compliance is a big issue. And finally, you have a psychogenic. Yes, Dr. Blakemore.
Hi, is that antihypertensive? Is that specifically beta blockers, Dr. Singh?
Beta blockers, yeah, beta blockers are one of the major ones involved in there. And when we were covering beta blocker, we actually talked about that as well. It's listed in the beta blockers. Is that what you're asking?
I'm saying yes, but I'm not unmuted. So yes, that's what I was asking.
Okay, yeah,
Thank
it's
you.
the beta blockers.
Thank you.
Just like in antidepressant, you have the SSRI is the main factor in there. And then you have a psychogenic condition that is related with the performance-related anxiety. And that's for your self-study and something that you will probably learn in your clinical medicine part. Here comes the mechanism of action of the drug. As I was alluding earlier, that of all those drugs which end in the FIL, they all belong to the same class. And there are 4 of those listed here. And again, this is also from UpToDate. And all of these drugs are actually inhibitors of a protein or enzyme called phosphodiesterase, a PDE. You know, the one question that always comes in is that, okay, there are so many drugs from the same class, which one to prescribe? And I've always said that that's not me who is going to tell you which one to prescribe. And I've written something here, again, that's from the UpToDate that says that from American College of Physicians, their recommendation is the choice of which of those drugs you'll use, it depends on patient's preference, including cost, ease of use, or desired duration of action. One of the things you'll see that Tadalafil has the longest half-life, close to 36 hours. And then I have a chart that summarizes individual properties of each of these drugs. So there are 4 of those. And then in the others, you have a yohimbine, which is basically a part of the supplement. So I'm not going to talk about that, but there's a lot of information about that on UpToDate. And the other drug here is called trazodone. You know, sometimes we talked about that. There are situations when a certain drug is used actually for its side effect rather than the intended therapeutic effect. And trazodone use in this erectile dysfunction treatment is actually because of its side effect. Otherwise, this drug is an antidepressant. One other important aspect about these drugs, that phosphodiesterase 5 is not only found in the human corpus, cavernosum smooth muscle cells, but it is also found in other places like platelets, vascular and visceral smooth muscle cells. And when you use these drugs, they're going to inhibit PDE5, all those places. And one of the advantages actually, it helps. It also works as an anti-platelet aggregation. So it prevents platelet aggregation and also causes vasodilation. So that's the other effect of these drugs. The first one, as I mentioned, doesn't end with FIL. So it has a different mechanism of action. So alprostadil, actually, it is available for local injection. And the way it works is a little different. It is actually a synthetic version of prostaglandin E. And prostaglandin E works with a receptor which is coupled to the stimulatory G protein receptor. And one of the things, if you recall, is that activation of stimulatory G protein coupled receptor results in increase in cyclic AMP levels. And that's what you see here. So by increasing cyclic AMP levels, actually it activates a downstream protein called protein kinase A, which then through downstream other protein decreases the intracellular calcium levels. And one thing, if you recall, remember that for a smooth muscle contraction, for any contraction, even in your heart, you need calcium. So if you decrease the level of calcium, you will cause the muscle relaxation. And from the first slide, when you saw that, the one way blood flow increases is by causing relaxation of vascular smooth muscle cells, and that's what exactly this drug does. So it is used for the treatment of erectile dysfunction as well as an adjunct for other diagnostic tests that is used for the diagnosis of erectile dysfunction. Warning and precaution, we'll cover that in the next slide. There's a long list. Adverse effect, this localized pain because it's an injection. And how does it metabolize? It's mostly metabolized through lungs and eliminated from your body through kidneys. So those are the important aspects of this drug. And as always, this information comes to you from FDA. And the red box here I have circled, that's where all the warning and precautions are listed. And those are the major concern with the drug. And some of them are local, like benzyl alcohol. If you look at that, benzyl alcohol is actually the preservative. It is part of a lot of different drugs, even heparin. And some of the reaction and side effect you observe with the heparin is also because of benzyl alcohol. So benzyl alcohol is a preservative that is used in a lot of different drugs, and some people are react to that. It's like a hypersensitivity type of reaction it can initiate. So that's the important aspect of this drug. Next, we're going to cover all the phosphodiesterase 5 inhibitors. So before we go on individual drug, I want to highlight the mechanism of action. So we were talking about the whole process of erection start with production of nitric oxide, which is produced from these two sources. They cause through the enzyme called nitric oxide synthase. And these enzymes make nitric oxide. Nitric oxide is a gas that can diffuse into the cells. And inside the cell, it activates its target called soluble guanyl cyclase. Soluble guanyl cyclase then converts GTP to cyclic GMP. And that cyclic GMP goes on and activates its target called protein kinase G. Just like adenyl cyclase or cyclic AMP, there you see the activation of protein kinase A. With the cyclic GMP, it's an activation of protein kinase G, which then, similar to what you saw earlier, it also goes and phosphorylates downstream protein, and that decreases calcium levels, and that results in smooth muscle cell relaxation, and that will increase the blood flow. So PD5 inhibitors actually PD5 is an enzyme that metabolizes cyclic GMP back to GMP, and then you lose all this function of the enzyme, what you see here, decrease in calcium levels. So by inhibiting phosphodiesterase, you are prolonging the levels of cyclic GMP, so there will be prolonged decrease in calcium levels and smooth muscle cells relaxation. So that's how these drugs facilitate their mechanism of action. The first drug which was developed in this class is sildenafil, and indication is the treatment of erectile dysfunction. Contraindication is actually pretty obvious. Nitrates, if you remember from angina lecture, nitrates also work through soluble guanyl cyclase and causes increase in cyclic GMP. So you don't want to use anything that can potentiate the effect of this drug. And hypersensitivity reaction, which is associated with the drug itself or the preservative in the drug. And you also don't want to use any other guanyl cyclase stimulator. And this drug, I don't know how exactly pronounce that, but Riociguat, this drug is actually an activator of soluble guanyl cyclase, and it is used for the treatment of actually pulmonary artery hypertension. That's where this drug is indicated for. So you don't want to use these drugs along with sildenafil. Warning and precaution, one of the things which is quite obvious with the drug description that they talk about and want you to aware of is the loss of vision and loss of hearing. Anytime your patient talks about having difficulty with vision or hearing, you have to recommend to your patient that stop taking this drug. And the other condition, hypotension, obviously these are all going to cause vasodilation, and so hypotension could be another consequence of that, especially when you're using with alpha blockers. Remember, alpha blockers causes vasoconstriction. Alpha agonist causes vasoconstriction. So if you use alpha blocker, they will also cause vasodilation, and using along with this drug, you can potentiate that effect. Adverse effect is all associated with the mechanism of action, which is vasodilation, drug interaction. All these drug interactions is driven by the metabolism of this drug. sildenafil is metabolized by CYP3A4 and CYP2C9. So as we have discussed quite often, that anytime when you have a drug that is primarily metabolized by one of these CYP enzymes, if you use concomitantly another drug that has either inhibitory, for example, here is ketoconazole, or something that increases, all the inhibitors will increase the plasma levels of this drug and can cause the overdose-like effect. Or you can use a drug that inhibit the enzyme or activate the enzyme. In those situations, when you activate this enzyme, most of the sildenafil will be metabolized and you won't see the therapeutic effect of that drug. So those are the drug interaction you have to be aware of. Also in HIV patient, ritonavir, if you recall that ritonavir is a protease inhibitor quite often used in the treatment of HIV. And some people are actually using a combination of ritonavir with other drugs, even for the treatment of COVID-19 actually. So you want to be careful with that. Anyone with the age over 65 years or having renal clearance below 30 ml per minute and the hepatic impairment, you want to start in those individuals with lower dose. And this is the FDA information, which is pretty much, I've highlighted all that we have already discussed, just to reinforce that that's where I get most of my information. And one of the things, if you notice right at the bottom, use in a specific population, it says that when you have a severe renal impairment, you want to start with the lower dose, like 25 milligrams. This drug is available in 3 doses, 25, 50, and 100. So anytime you see a severe renal impairment or even hepatic impairment in those situations, you want to start the lowest possible dose, which is 25. And the same goes with the age factor as well. Anyone over 65, you want to start with 25 milligrams. So those are the important information I would like you to remember about this drug. So I'm not going to talk about into every single drug in this class, but to highlight the important information through the use of these drug monographs. So other drug in this class is avanafil, which has the same indication, same mechanism of action, PD5 inhibitor, and you can see in the boxed information, they basically similar to what we saw in the previous drug. Don't want to use with the drug that activate guanylyl cyclase, has a similar effect. One thing which is different between this drug and the previous one is actually used in a specific population. That's why I have an arrow there. In the previous sildenafil, they recommend that you start with the lower dose in certain situations. Here, if anyone has a severe renal impairment or a hepatic impairment, they don't recommend you to prescribe these drugs in those situations. So that's pretty much our discussion on PD5 inhibitor, and tadalafil will talk about that when we come down to benign prostatic hyperplasia. Yes, Dr. Blakemore.
Hi, Dr. Singh. So
Yeah.
a couple of things. So not really supposed to use these like if a patient presented to the ER before you gave them a nitrate for an MI, you would want to ask them if they took anything for erectile dysfunction because of that
Right.
hypertension, right?
Yeah.
And then my other question is, what's the duration? Because I've always heard that, you know, an erection longer than 4 hours prompts an emergency room visit. Do you have a duration of time for these types of drugs?
Right. If you look, it will come down to that. There is a table and chart I have that I've taken from UpToDate that talks about all of that. The duration, it should not last more than 4 hours. None of these drugs effect should last more than 4 hours. If you have the effect is still persisting after 4 hours, then that is a situation you have to see the emergency department. And that's what exactly listed in the warning and precautions. Patients should seek emergency treatment if an erection lasts greater than 4 hours.
Okay, thank you very much.
None of these drugs should have effect more than 4 hours.
Okay, thank you.
Mm-hmm. So next we're going to move on to other drugs that are listed in this for the treatment of ED, and that includes trazodone. So the trazodone, I was talking about that. It's an antidepressant actually. And the way it works as an antidepressant is it inhibits the reuptake of serotonin, just like your SSRIs do. And also it antagonizes serotonin 2A receptor. So that's its mechanism of action for your antidepressant effect. What it is used here is for a psychogenic ED. And you can just, when you go on UpToDate, just search for trazodone. That information which is listed here in the indication is straight from UpToDate. That's why it says reference UpToDate. It is used for psychogenic ED. How exactly helps? I don't have exact mechanism of action. Neither the FDA document describes that clarity in terms of mechanism as a treatment for ED. Contraindication is important here because at the end of the day, the way this drug works is by increasing the serotonin levels. So you don't want to take anything, either the diet or medication, that could increase serotonin levels more than your body handles, because if it goes beyond a certain level that can process by your body, you'll end up having a risk of serotonin syndrome. This is too much increase in serotonin levels, and there are symptoms associated with that. That's called serotonin syndrome. So you want to avoid taking this drug along with anything that increases serotonin levels. And one other thing you'll notice here, patient taking or within 14 days of stopping monoamine oxidase, you should not start this drug. Why that number 14 days is listed here? Anyone has any idea on that? Why specifically 14 days? Why not 7 days or 10 days or 15 days, a month? Anyone?
Is that how long it takes for the neurotransmitters to like I guess, like, I don't know,
You're getting close.
built
That's
again? I
Madeline,
don't
right?
know.
Yeah, Madeline, you're close.
Just kind of like when their levels get back up. I don't know how to say this.
Yeah, no, think about that. What drug listed here? Monoamine oxidase inhibitors. I mean, we haven't covered that drug, but you're pretty close. So monoamine oxidase inhibitors inhibit an enzyme, as inhibitors in the name. They inhibit an enzyme called monoamine oxidase. What are monoamine oxidase? Monoamine oxidase are the enzyme that metabolizes those neurotransmitters. So you're very close. So they metabolize that. But when they bind to that monoamine oxidase, they irreversibly bind to that. So your body will have to synthesize the whole monoamine oxidase amount from scratch, because all of them which are bound to this drug, they're no longer functioning. And that could precipitate increase in serotonin levels if you're taking some other drug that works similarly and increases the serotonin neurotransmitter levels. That's what, so that takes, for your body, it takes around 7 days to synthesize and replenish all those monoamine oxidase enzymes. So 7 days for the synthesis, 7 days for these enzymes to move out to the different places in your body, because they're also located in your GI tract. Remember, 90% of serotonin is produced in GI. It functions as a GI hormone down there. So these enzymes are expressed there as well. So overall, to be safe side, that you have enough monoamine oxidase enzyme, this 14 days period is given. So you should not take anything within 14 days. If you're taking monoamine oxidase and you will stop taking it. So wait for 14 days before you give something that increases serotonin levels. Adverse effect, edema, blurred vision, syncope, drowsiness, fatigue. It's all associated with the neurotransmitter action. Drug interaction, we'll go on the next slide and look at it a little bit. How does it get metabolized? Again, it's metabolized by CYP3A4. And reiterating, probably I may be sounding like a broken record, but every time when you see a CYP enzyme and some isoform in there, you always have to be very careful that you should not take any other drug that is also metabolized by 3A4 or has inhibitory or stimulating effect on the activity of that enzyme. One of the drugs we covered in the previous lecture, last lecture, one class of drug that is exclusively metabolized with CYP3A4. Anyone remembers that drug? Remember corticosteroids? They are metabolized with CYP3A4 as well.
I have a quick question.
Yeah.
Going back to the slide before, is psychogenic ED the same thing as performance anxiety related ED?
Like, that's what it says in the, if you go back to all the way to the previous slide And I think the up-to-date what we have is there. If you look at psychogenic, that's what it says: performance-related anxiety, traumatic
Okay.
past experience, relationship problem, anxiety, depression, and stress. So yeah, I believe
Okay.
so. I'm not going to talk about the pathology or even physiology of the disease. Joe, I'm not qualified for that, so I won't go there. One other thing I want to highlight from here is if you look at that, the warning says suicidal thought and behavior, but one thing if you notice from the previous slide, the dose is used, a dose of the trazodone that is used for the treatment of erectile dysfunction is a lot lower than the drug dose that is used for the treatment of depression. So I don't know how relevant this warning is, but since it is a drug that increases serotonin levels and used as antidepressant, you always have to be careful with those warnings, suicidal thoughts and behaviors. Other thing listed here, those drug interaction, you want to be careful with that. Like CYP3A for inhibitors, you want to reduce the dose. Obviously, we know that because less of the drug will be metabolized, it will be longer. Level of plasma level of this drug will be higher with any concomitant administration of drug that inhibit 3A4 activity. In terms of end users, you have to increase the dose to maintain the therapeutic dose. So those are the other drug interactions. You want to be careful with that. So that's about trazodone. And if you look at that, in one of the warning and precautions which I've highlighted here, priapism, which is a case of painful and prolonged penile erections in priapism has been reported. And that is what actually used, although at the lower doses for the treatment of ED, even though this drug is approved for the treatment of depression. So that side effect what makes it relevant for the treatment of ED. Next, we're going to move on to the other drug class that we're going to cover is the treatment of drugs that are used for the treatment of benign prostatic hyperplasia.
I have a
So what
question
is
real quick.
BPH? Yes.
I have a question before we move on.
Okay.
So I know that you just briefly mentioned priapism,
Yeah.
and I had a question specifically for that. With the Viagra, you have underlined use with caution in patients predisposed to priapism.
Right.
So does that mean that we should be screening all of our African American males for like, oh my God, why am I blanking right now? The blood dyscrasia disorders before we prescribe these drugs? Or sickle cell, sorry, I couldn't think of it. But sickle cell is predisposed priapism disorder. So
if it is, I mean, thanks for bringing this up, Lisa, because I'm not aware of that. I'll look it up, but at this point, I don't know if the screening is required for anyone who is predisposed to that condition before you prescribe these drugs. So I'll have to look it up. To be honest with you, I'm not aware of that.
thank you.
Mhm. Anyone has anything on that so far, what we've talked about? Okay, so we're going to move on to BPH. What is BPH actually? What happens in the BPH? This is all we can talk about the disease, what I have on this slide. Is if you look at that, in the left side, you have the normal bladder, prostate, and urethra. That tells you that there isn't any issue and urine can easily flow out from once the bladder gets full to, I guess, 2/3, then you get the urgency to deteriorate. In that case, urethra is properly dilated so the urine can flow. What happens in BPH is you have this overgrowth or hyperplasia of the prostate gland, and that kind of compresses urethra. And that actually interferes with the urination. It makes it difficult to urinate, makes it painful, and that's what is underlying condition in BPH. And this is all we're going to talk about the disease. Anyone else want to contribute to that? Because that's my limited knowledge about the disease and the pathology. If not, then we go on and talk about the treatment. So there are different classes of drugs that are available for the treatment of BPH. And those are listed here. Again, this you can find in the up-to-date. That's the reference where this information came from. You have alpha-1 adrenergic antagonist, and they're easy to remember because all of them ends with SIN, sin. And then you have the second class of the drug, that's 5-alpha reductase inhibitor. There are two drugs in this class, finasteride and dutasteride. And again, it's the similar sounding names. You'll remember they belong to this class. And then you have an anticholinergic agent, which are mostly not exactly used for BPH, but also used for the treatment of overactive bladders, urinary incontinence, and all that conditions. We'll talk more about when we get there. And finally, you have phosphodiesterase 5. One of the phosphodiesterase 5 inhibitor, Tadalafil, is also used for the treatment of BPH. And one of the reasons, my guess is that it has the longest half-life among all phosphodiesterase 5 inhibitor. It's around 36 hours. So alpha-1 adrenergic antagonist. If you guys remember that from the autonomic pharmacology lecture, distribution of all this adrenergic receptors into the different parts of your body, one place where alpha-1 receptors are expressed a lot is in prostate, bladder base, neck, and urethra. All these places, alpha-1A receptors are expressed. And when you activate these alpha-1A receptors, they cause smooth muscle contraction in the prostate, bladder base, neck, and urethra. And so to avoid that, when you're already having compressed urethra and difficulty urination, if you block the activation of alpha-1 by using alpha-1 blockers, you actually alleviate some of the symptoms of BPH. So it's basically symptomatic relief. It's not going to do anything to the prostate growth or enlargement that is compressing the urethra. Other than that, it's just dilating the smooth muscle cells of urethra, so make it easy for the passage of urine. So that's the underlying physiology of these drugs. So first drug in this class is tamsulosin, and indications used for the sign and symptoms of benign prostatic hyperplasia. It is not indicated for the treatment of hypertension. And to understand that, you have to go back again to your autonomic pharmacology lecture, because alpha-1 receptor also has 3 different subclass. Alpha-1A that you saw in the previous slide, if you look at that, it says alpha-1A. There are 2 other subclass of receptor in there, alpha-1B and alpha-1D. So alpha-1A is exclusively expressed on the prostate and urethra, all those places we talked about in the previous slide. Alpha-1B expressed there and also on the vasculature. And alpha-1D is mostly expressed in the vasculature. So if you have a drug that blocks both alpha-1A and 1B, you can cause actually a vasodilation as well as a relaxation of urethra. But since we're talking about the benign prostatic hyperplasia, this drug is exclusively, tamsulosin is exclusively target or has a selective action on alpha-1A receptor. That's why it has no use in the treatment of hypertension, because alpha-1A receptors are exclusively expressed on prostate and other tissues, not on vasculature. Contraindication, there is none except hypersensitivity that is associated with the drug itself. And then you got all these adverse side effects of the blockade of alpha-1 receptor. Drug interaction, again, long list, we'll talk about that on the next slide. And in terms of pharmacokinetics, it is metabolized by these 2 enzymes, 3A4 and 2D6, and mostly eliminated by kidneys, gets out through urine, 76%, and then feces, 21%. So having those CYP enzymes, again, brings you the drug interaction into picture. Anytime you have, and some of those drugs are really common that you might want to remember, like moderate inhibitor of 3A4, erythromycin. Erythromycin is used a lot. So you might want to remember the moderate inhibitor of CYP3A4. And also, when you talk about the other known inhibitors of that, like CYP2D6, remember CYP2D6 is important for metabolizing codeine to morphine. And that could also impact the metabolism of this drug. If anything, that increases decreases the activity of 2D6. So basically, the most of the drug interaction for this drug is actually associated with the concomitant administration of anything that could affect the enzyme activity. And that's where most of the precautions and warnings are also related. So that is about this drug. Next drug of the same class has exactly same effect. And one thing before, let me go back and highlight that this drug has not been studied in conditions like renal impairment and hepatic impairment. If you need to adjust the dose in those situations, there isn't any information out there that can tell you one way or other, either reduce the dose or increase the dose. But in this case, this new drug actually has a specific recommendation. Everything else is same, just like the previous drug. It also acts as alpha-1 antagonist and not recommended for the treatment of hypertension, similar metabolism, 3A4 and 2D6. And there is a contraindication that is associated with the severe renal impairment. Anytime you have a creatinine clearance goes below 30, you have to be careful with the prescription of this drug. A specific population, that the thing I want to highlight here is that in renal impairment, dose adjustment is required in moderate diseases, contraindicated completely in severe renal disease. So you don't want to give this drug someone who has a very compromised renal function, and also in hepatic impairment. So those are the conditions you have to be careful when you're thinking about this drug. Other interactions are related with how this drug is eliminated. Remember, if you recall the function of this P-glycoprotein, these are the protein that helps remove the drug from the cells and that facilitate the elimination of the drug. So if there is any drug you're taking, for example, it's given here cyclosporin, which is an inhibitor of P-glycoprotein, you can cause accumulation of the drug. And that would have an adverse effect because too much of drug is circulating in the plasma. And also do not use along with the PDE5 inhibitor that can cause symptomatic hypotension. The next class of the drug for treatment of BPH is 5-alpha reductase inhibitor. And we talked a little bit about earlier when we were talking about, I guess, herbal medications. We talked about some of the herbal drugs have effect that can be used in the BPH. So if you recall, the pathophysiology of BPH is the enlargement of the prostate gland. And one of the physiology of that enlargement, how does the enlargement is supported, is by increasing levels of dihydrotestosterone. So normally you have in your body, you have a testosterone is circulated, but that is not the most biologically active testosterone. It has to be converted into dihydrotestosterone by these two enzymes called type 1 and type 2 5-alpha reductase. So these are the enzymes that convert testosterone to dihydrotestosterone, which then has this mitogenic effect that supports enlargement and growth of the prostate gland. And then when the prostate gland enlarges, it's going to compress urethra and makes it difficult to urinate. So if you inhibit that enzyme activity, which you can limit the conversion of testosterone to this active compound, and that will prevent the growth of a prostate gland and developing hyperplasia. So that's how 5-alpha reductase inhibitor work in the treatment of BPH. So first drug is finasteride, which is used as a monotherapy for the treatment of symptomatic BPH. In men with an enlarged prostate, to improve symptoms, there are 3 ways: improve symptoms, reduce the risk of acute urinary retention, and also reduce the risk of the need of surgery, including transurethral resection of the prostate. I honestly have no idea what that involves, what that entails, but that's what this drug is indicated for. It is also used in combination with alpha blocker. The doxazosine is to reduce the risk of symptomatic progression of BPH. So both as a combination, as a single drug, there is specific use of this drug. Contraindication, hypersensitivity reaction because of the nature of the drug, and anyone who has, in the women who are or may potentially be pregnant. And adverse effect, again, it involves the drug actually prevents conversion of testosterone to active compounds, so it might cause a side effect like impotency, decreased libido, decreased volume of ejaculation, and others. Drug interaction, none that is out there are recommended by FDA. It is extensively metabolized in liver. primarily via cytochrome 3 or 4 enzyme. So again, you have to be careful with the drug interaction and other drugs that you're taking along with that drug. That's pretty much what FDA has out there for you to know about this drug.
Dr. Singh,
It is,
what
yes,
are the
go ahead.
what are
Annabelle.
what are the impacts on women who are pregnant if they give this drug?
To be honest with you, what exactly it does, I cannot describe. The one thing I don't know, it could be like talking about the breast enlargement, breast tenderness, rash, and all that. Whether that has a clinically any effect on the pregnancy itself or the fetus, I'm not aware of that, but I can definitely look it up. Let me write it down. What happens? I'll definitely look it up and let you know if there is something out there.
Thank you.
Anyone else? Anybody has any other question on that? One thing that it does discuss here, when pregnant or potentially be pregnant due to potential risk to a male fetus, that's all it is out there in this one. But I'll read up more if there is any more, there is any extra information out there. But this is so far from the drug monographs. Okay, anticholinergic agent. How does anticholinergic agents help in this process? And this will again make sense if you go, if you recall, review your autonomic pharmacology lecture. This has to do with the expression of the receptors. So if you look at the detrusor muscles, actually on bladder express M3 muscarinic receptors. So what this cholinergic, when you have acetylcholine release, which activate muscarinic M3 receptor to cause contraction of detrusor muscle, and basically increases the sense of urgency, the feeling of urination. So you can treat that if you block the muscarinic receptor from being activated by acetylcholine, you can cause a relaxation of smooth detrusor muscle and also decrease urgency for urination. So that's how these drugs work. This drug here is a muscarinic antagonist indicated for the treatment of overactive bladder with symptoms of urinary incontinence, urgency, and urinary frequency. Contraindication, urinary retention. Obviously, one of the ways you feel urge for urination is the contraction of detrusor muscles, and if you block that, it might cause increase the risk of urinary retention. If someone already has underlying condition, you don't want to prescribe this drug to those individuals. Gastric retention, uncontrolled, again, the pressure buildup and uncontrolled narrow angle glaucoma in patients who have demonstrated hypersensitivity to the drug. And again, if you look at the glaucoma angle, you'll understand if you go back and review the expression of those receptors, muscarinic receptors. So if you're blocking in one place, drug is going to block the muscarinic receptor at other places as well. Adverse effects are dose dependent. It can cause dry mouth, constipation at both 5 and 10 milligram dose, and urinary tract infection and blurred vision at 10 milligram dose. This is one of the drugs that depends on the dose, you'll experience the different side effects. Drug interactions, since it is metabolized by 3A4, so any inhibitor, and especially when you're taking any other drug that inhibits CYP3A4, in those individuals, you should not prescribe more than 5 milligram daily dose. And also you need to adjust the dose in someone who has underlying hepatic and renal conditions. And that's pretty much what this drug is all about. And we already talked about those indications. There is nothing more than we discussed that you need to know about these drugs. The reason I have all these FDA monographs, you know that, so we can make sure that we covered everything what we need to. And some of the contraindication, like warning and precaution, especially if you look at that, it talks about QT prolongation. Use with caution in patient with a known history of QT prolongation. A patient who are taking medication known to prolong QT intervals. So you want to be careful in those. Which class of drug prolonged QT interval. Do you guys remember that? We discussed that in antiarrhythmic lecture. If you recall, it's like class 3. And there are a lot of drugs that can cause QT prolongation, antidepressant, antipsychotics, and other class 3 antiarrhythmics as well, like amiodarone and others. So you want to be careful in those individuals prescribing this drug. This drug also belongs in the same class, and it is used for the treatment of overactive bladder with symptoms of similar symptoms, urinary incontinence, urgency, and frequency as for the previous lecture. Contraindications, similar contraindication, adverse effect, headache, dyspepsia, back pain, myalgia, nasal congestion, flushing, and limb pain. So there are one other component that is you have to be careful with is the pain part. Drug interaction is dry mouth and constipation. You'll see a lot of adverse effect which is related to all the anticholinergic effect. Remember, if you go back to again our discussion on autonomic pharmacology, there is a whole list of the side effect which is associated with blockade of muscarinic receptor, what we call the anticholinergic effect. So all those effects will also be experienced by anyone who is taking these drugs because it is an anticholinergic drug. Pharmacokinetics, hepatic metabolism, and renal expression metabolized predominantly by 2D6 and 3A4. So you want to be careful with the concomitant administration of anything that could affect the activity of these two CYP enzymes. Indication is the same what we talked about, that overactive bladder, frequency, and be careful in anyone who has a severe renal impairment when the creatinine clearance goes down below 30 milliliter per minute. And anyone who is taking potent 3A4 inhibitors, that's ketoconazole, clarithromycin, itraconazole. Side effects, we talked about that, basically anticholinergic side effects like dry mouth, constipation, and others. So that's pretty much about this drug. And now we're going to talk about this drug, phosphodiesterase 5 inhibitor, which is also, most of these drugs are used in the treatment of ED, but this drug is also used in the treatment of BPH, which is Tadalafil. We'll talk about how does it work. If you look at the expression of, we talked about that, PD5 is also expressed in different places in the body. And the places where you see the most expression is also in the detrusor muscle, urinary, the bladder, prostate, stromal smooth muscles, extrinsic striatal muscles, intrinsic smooth muscles, vascular smooth muscles, all those places, detrusor smooth muscles, they also express PDE5. So when you have a PDE5 inhibitor that has a long half-life, it will also inhibit these PDE5, and that helps with actually relaxation of smooth muscles and facilitate a urinary passage. So Tadalafil indication, the FDA approved indication is treatment of erectile dysfunction, benign prostatic hyperplasia, and erectile dysfunction and benign prostatic hyperplasia, someone who has both these conditions. This would be a good drug to think about that. Contraindication, you don't want to give anything that increases nitric oxide levels and relaxation of smooth muscles that include your nitrate and other gonadal cyclase stimulators. Adverse effects are headache, myalgia, nasal congestion, flushing, and pain. Since metabolized by 3A4, you have to be careful with the drug interactions as well. And one of the drug that is one of the few drugs that are actually inducers of 3A4, like rifampin, you also have to be careful with that. Pharmacokinetics, dose adjustment, that's the other drug that requires dose adjustment when you have underlying hepatic and renal impairment situation. That's pretty much about this drug. And these are the FDA approved indication, drug interaction, side effect. We already talked about that. If you look at that in the last used in specific population, what it talks about that in mild to moderate hepatic impairment, you can adjust the dose and can still prescribe it. But when it comes down to severe hepatic impairment, this drug is not recommended. Similarly, if we talk about the renal impairment, anyone has a clearance 30 to creatinine clearance of 30 to 50 ml per minute, dose adjustment may be required. Anytime when you have a clearance drop to below 30 ml per minute, it says that the use as needed and should not exceed 5 milligram every 72 hours. So in those individual, daily dose is not recommended. So those are the things you want to be careful with this drug. And this is the chart and what I was talking about, the really nice summary of all the drugs we talked about in the treatment of ED actually. And this is from your up to date, and that's the latest information we have. Summarizes it really well. What we've talked about, all those things are actually listed here as well. And I haven't seen anything that we didn't talk about. So I haven't highlighted anything. But I'm just going to go quickly and highlight one thing on Tadalafil. If you look at the duration of action is 36 hours. And I guess that's the reason we can use Tadalafil for the treatment of BPH, because think about that. BPH is a condition that is not going away. All the treatment we talked about, that all of them are actually somehow facilitating passage of urine by controlling the level of the contraction of those statorosal muscles or urethral smooth muscles. So that's all we are doing. We are providing symptomatic relief. So if you are, if surgery is not involved, as long as you're taking a drug to provide symptomatic relief, it's a long-term treatment. So having a half-life of 36 hours, a duration of action for 36 hours, it doesn't require you to take this drug every single day. And that kind of improves the compliance and also its use in treatment of BPH. So that was one of the things I could come up with, why only Tadalafil is used for the treatment of BPH and not other phosphodiesterase inhibitors. So this is a nice source, actually, all the information in one place. And one of the new drug, Avanafil, if you look at that, the onset of action is actually 50-30 minutes faster than the sildenafil, which is the first drug approved in this class. So that's the advantage of this drug. And all this factor plays into which PDE5 inhibitor you're going to prescribe to your patient. All this will be actually a factor in deciding one drug versus other. And Lil talks about a little bit of yohimbine, and I won't ask anything since it's a supplement, not an FDA-approved indication. And that's why I didn't get into that, but you can read up a little bit. And trazodone, as we talked about, that those are the pretty much what is listed here as well. So that covers the first part of the lecture, treatment of urological disorder. And here are some of the questions that based on the information we covered. So why don't you guys read it and give it a shot, and we'll see how this works out. Just raise your hand when you're ready and you know the answer. Anyone? Any guess so far? Anybody? No one? Take a guess. Just take anything. We'll go with that anyway. I'll explain you the answer.
B.
Hmm?
B as in boy. Tim Solo.
tamsulosin. Anybody else? Okay, focus on the key phrase and key word in that question, as I've discussed previously as well. So what is going on here? Someone with the BPH, right, continue to have the symptoms, and this new drug is added, dutasteride. But in addition to all that drug, he's also taking hydrochlorothiazide, probably for his hypertension, testosterone, and vardenafil, which is your PDE5 inhibitor, as needed. Which of the medication could have an interaction with dutasteride? What does dutasteride does actually? What is the mechanism of action? It inhibits that enzyme. Remember, 5-alpha reductase that converts testosterone to dihydrotestosterone. So the one drug that could interfere with that will be a testosterone, because once you overload the testosterone, because that guy is taking that, it could be a problem with dutasteride. The inhibition of alpha reductase would not be enough. So if you have overload of testosterone, it could, some of that could be converted to your dihydrotestosterone, and that could create a problem with the BPH. So that's what I'm looking for. Anybody else wants to chip in? Anything? Any thoughts? Does that make sense? Why testosterone here? Okay, so moving on to the next one, give a shot to this one.
Nitro.
Fantastic. Why?
It can cause hypotension if you take it with a PDE5 inhibitor.
Right, it pretty much going to increase the nitric oxide level. It's going to do the same thing. If you recall that anti-general lecture, there's a big slide on that, talks about the mechanism of action. So yeah, nitro is the good response on that. So that's wonderful. So now the next part of this lecture, we're going to talk about the overdose or drug toxicity, also known as clinical toxicology. So basically what we are talking about here is some of the commonly prescribed drug, and there is always an accidental overdose that happens. And this is actually an important topic to be aware of, that how do you first of all deal with the overdose of poison, and when actually you can mount an effective treatment to control the symptoms of overdose. So one of the first things that involves in this process of overdose is decontaminations, right? You will try to get rid of the drug that someone is overdosed. It doesn't matter which route, it's ingestion, orally, or injected, or dermal. As long as the drug is more than it's supposed to be inside the body and has the detrimental effect, you have to take it as overdose and try to treat for that. So decontamination, which involves gastric lavage, activated charcoal, and other process, it is basically trying to get rid of drug as fast as you can, so that drug doesn't stay long enough to produce those side effects. And that's why it should be administered. If you want to do decontamination, you should do that preferably within 1 hour of ingestion, so that drug hasn't gone into circulation and is not starting to cause damage. And there is ways that you can actually enhance the body's response of which is trying to eliminate by the process that's called elimination enhancement, through the process of like hemodialysis, that involves actually certain condition. If the drug that individual is overdosed on has a low protein binding, a small volume of distribution, because think about that, if it is a really high protein plasma protein binding affinity, then it's not going to come off easily. It will only slowly come off when the drug level in plasma start going down. So there are certain drugs only work in this approach, something that has a low protein binding. Again, a small volume of distribution. What is a small volume of distribution? Something that stays inside the circulation and you can easily get it out through hemodialysis. Once it is made to the distribution and gone through the cells and tissues and accumulated, it's difficult to get rid of that drug through hemodialysis. So it has to be something has a low protein binding, a small volume of distribution, a small in size, molecular weight, and water soluble. And those criteria is met by these drugs like salicylate, theophylline, phenobarbital, and lithium. Remember all these drugs, and especially lithium is a narrow therapeutic index drug. So the drug levels, anytime you have an overdose with the lithium is going to have a very serious detrimental effect, and same with theophylline. Salicylate is most commonly consumed drug, so you wouldn't be surprised. I wouldn't be surprised if you see someone in your clinical practice overdose on salicylates, another drug. Other approach would be urinary alkalization. And that only works with that. When you causing alkalinization, it only works for the drug that are acidic in nature, like salicylates or phenobarbital. You increase the pH of the urine and cause the dissociation of these drugs. Once the drugs are ionized, they are not going to get reabsorbed. The only way these drugs can go is gets eliminated through your urinary route. And other approach is multiple dose activated charcoal that enhances elimination of certain drugs, like again theophylline, phenobarbital, digoxin, carbamazepine. And again, if you notice that some of these drugs are narrow therapeutic index drugs, so that's why the urgency is you try to get rid of it anytime you have overdose. And with the digoxin, you have another option as well by using the digibind in anybody that binds with digoxin and helps the elimination of the drug. This approach also blocks the reabsorption of medication that undergone intrahepatic recirculation. That is what it is showing. Because of the large surface area, most of the drug is absorbed in GI on the activated charcoal and does not make it to this recirculation, hepatic recirculation. Once they are absorbed on the surface of activated charcoal, the only way for them is to get out of the body. The drugs which are, this approach is helpful in eliminating include lead and other heavy metal ions, lithium, potassium, and alcohol. They do not bind with the activated charcoal. So these drugs, these drugs won't be, this approach won't be helpful for those compounds like iron, lithium, or potassium because they won't bind to activated charcoal. So we're going to talk about some individual drugs overdose, which is very commonly seen. Acetaminophen is one of those. And if you recall, the metabolism of acetaminophen is metabolized through cytochrome enzyme and is converted into a toxic intermediate that's also known as N-acetyl parabenzoquinone imine, or in short, NAPQA. So the way your body handles it, once it's metabolized to this intermediate, it gets converted into non-toxic compound with the help of glutathione right here. So this is a normal process how your body get rid of acetaminophen. Think about the overdose. When you overdose and too much of acetaminophen in your system, you saturate all the available glutathione. You don't have enough glutathione to get rid of or convert all the toxic NAPQA into the non-toxic mercaptouric acid that gets eliminated in urine. What will happen then, the NAPQA will start accumulating and it will also start binding to a nucleophilic hepatic cell protein, and that can cause death of those liver cells or hepatocytes. So it's important for you to treat the overdose of acetaminophen. And again, there is another factor in there, is the time factor. If you look at the side effect or the toxicity, what happens is divided into 4 phases. Within 0 to 24 hours, you're going to experience something like loss of appetite, nausea, vomiting, and other conditions. In phase 2, from 24 to 72 hours, it can start with the abdominal pain, increased liver enzyme because liver is trying to respond to the death of the hepatocytes. So in phase 3, which goes from 70 to 96 hours, you have liver necrosis because more and more cells are dying. And all the bilirubin is coming off that will manifest as a jaundice, encephalopathy, and renal failure and death in phase 4, when there is already a death, 4 days to 2 weeks, complete resolution of symptoms and organ failure. One important thing to remember is when do you want to treat that? And this graph here is called nomograph, N-O-M-O, nomograph. What it is telling you is that when is the best time to intervene and think about treating the overdose acetaminophen. If you look at that, if you are able to give the drug between this part here, if you look at the up to 50, what you see your microgram per mil, this is the probable hepatic toxicity drug concentration. But any time it falls below 50 to 100, and that happens after 12 to 16 hours. So if you didn't intervene by 4 hours and you waited till 12 hours, there is no advantage of trying to treat the overdose after 12 hours because the drug concentration has already fallen below to the level that causes the drug toxicity at this point. So the damage is already done. So if you want to intervene, and that's what the next slide will talk about, you want to intervene early. And the way you want to treat it, there is a drug specifically approved for treating acetaminophen overdose called N-acetylcysteine, or NAC, which is an antidote for acetaminophen overdose indicated to prevent or lessen hepatic injury after ingestion. In patients with acute ingestion, that's where the time factor comes in play. How does it work? It actually works 2 ways. One, your body uses glutathione to get rid of the toxic intermediate. So this drug helps facilitate regeneration of glutathione. So it helps make more glutathione available to neutralize the toxic metabolite. At the same time, it also binds directly with the toxic metabolite to detoxify and prevent the toxic metabolite from causing damage. So there are 2 ways N-acetylcysteine actually helps reduce toxicity of acetaminophen overdose. Adverse effect, hypersensitivity reaction, which is related to the drug, risk for upper gastrointestinal hemorrhage, nausea and vomiting, and other GI symptoms. It undergoes extensive first-pass metabolism, and it is postulated to form cysteine and disulfide bond. And cysteine is further metabolized to form glutathione and other metabolites that also helps with neutralizing the toxic intermediate. And here's the drug monograph from the FDA. And if you look at that, that's where it talks about the doses and administration. Obtain a plasma sample, a serum sample to assay for acetaminophen concentration at least 4 hours after ingestion. Because if you look at that, the nomograph, you can see that here is the 4-hour window. So at least that's where this 4-hour time period comes for, at least 4 hours after ingestion. If the time of acetaminophen ingestion is unknown, then you administer a loading dose of this drug immediately and obtain acetaminophen concentration to determine the need for continued treatment. If the acetaminophen concentration cannot be obtained or unavailable within the 8-hour interval after someone overdosed on acetaminophen, or there is a clinical evidence of toxicity, in that case, go ahead and administer a loading dose immediately and continue the treatment for a total of 17 doses. If the patient presents more than 8 hours after ingestion, then administer loading dose immediately. And also the last one, if the patient presents less than 8 hours after ingestion and the time of acute acetaminophen ingestion is known and the plasma concentration of acetaminophen is known, then you use the nomograph, what we talked about, to determine whether or not to initiate treatment. Because if it's already late where the concentration is dropped, then there's no point in using that drug. So those are the things you have to take into consideration for treating acetaminophen overdose. It talks about the dose here, and also in a different age group. Other one we're going to talk about is methanol and ethylene glycol toxicity. In the next slide, we'll see what are the sources of methanol and ethylene glycol. But the way we treat that when there is a chances of methanol ethylene glycol toxicity, use a drug called fomepizole. So fomepizole it is an inhibitor of alcohol dehydrogenase because the toxicity with the overdose of methanol ethylene glycol is associated with the formation of these formation of these metabolites like formic acid in case of methanol and calcium oxalate crystal in case of ethylene glycol. And that requires these intermediate reactions before it can form, methanol gets converted to formic acid. But the first enzyme in this pathway is alcohol dehydrogenase that converts methanol to formaldehyde. So if you inhibit this conversion, methanol is not going to be forming formic acid, and you wouldn't experience this injury like retinal injury or permanent blindness. So that's how we treat methanol poisoning. Same with ethylene glycol. If you inhibit alcohol dehydrogenase, it's not going to be converted to glycoaldehyde or all the way down to calcium oxalate. So you're blocking the first step itself. And with that blockade, you prevent the formation of this metabolite that has actually a toxic effect. This is about methanol and ethylene glycol toxicity. Methanol is found in products like windshield washer fluid. And again, accidental ingestion for some reason could get the methanol in the system. And also in the model airplane fuel. Ethylene glycol is most commonly found in radiator antifreeze. For some reason, someone ingests antifreeze, you are going to have the ethylene glycol toxicity. And they themselves are relatively non-toxic, as we are looking in the previous slide, and mainly cause the CNS, but once they convert into the metabolite, that's where the toxicity is going to come from. And we talked about these methanol and ethylene glycol oxidized to toxic products forming acid in case of methanol, and glycolic, glycoxylic, and oxalic acid in case of ethylene glycol. Symptoms, other thing about that is when, in case you have a patient that shows up in the clinic or emergency department where you're working, and patient is not conscious enough, for some reason, is not able to tell you what actually that person has ingested, whether it's acetaminophen or it's one of those methanol or ethylene glycol exposure. So in that case, it's important for you to recognize the symptoms. I mean, it's not pharmacology to tell you about the symptom, but you want to remember what are the symptoms of overdose or poisoning of these drugs. That will help you decide, once you diagnose what is the underlying cause, a chemical, then you can think of the treatment, because if it's methanol, ethylene glycol, you're going to go with fomepizole for the treatment of toxicity. So the treatment is fomepizole, as we talked about that. In case you don't have fomepizole, what you can use is ethanol, regular ethanol, which you can use to treat methanol ethylene glycol activity. Let me go back to the previous slide. So how does, if suppose you don't have fomepizole, how could you use ethanol to prevent the toxicity of either methanol or ethylene glycol? How do you think that works? Anyone has any thought on that? The idea is that you don't have this drug, and you know that it's a methanol poisoning or it's a ethylene glycol poisoning. All you have at your disposal is the ethanol, and you know that it's going to work. So how does ethanol helps with methanol or ethylene glycol toxicity? Anybody? Okay, that has to do with actually how the ethanol gets metabolized. Ethanol is also gets metabolized the same enzyme, alcohol dehydrogenase. Ethanol is also an alcohol, right? Alcohol dehydrogenase. So when you have ethanol, what you're doing is that you're transferring, occupying most of this alcohol dehydrogenase enzyme in metabolizing ethanol, which doesn't have any toxic metabolite. So you basically directing most of the enzyme to work with the ethanol, and not much is available to metabolize methanol or ethylene glycol in this case. So when less methanol gets metabolized, less toxic metabolite is going to be formed. So basically you are diverting most of the enzyme towards ethanol, away from methanol or ethylene glycol, and that's how actually ethanol helps in the treatment of either methanol or ethylene glycol toxicity. Hemodialysis can be helpful to remove the toxic acid that are already produced. In addition, cofactors are also administered to increase metabolism of non-toxic metabolite. So those are the ways you can treat these conditions. And remember, the symptoms are important. Methanol ingestion can produce blindness, metabolic acidosis, seizures, and coma. Ethylene glycol ingestion can lead to renal failure, hypocalcemia, metabolic acidosis, and heart failure. Next one is carbon monoxide. I guess you guys are more aware of this thing than I do. So what happens with carbon monoxide poisoning? It binds with hemoglobin, right? Two things happens. It takes away your hemoglobin that is supposed to bind to oxygen and deliver oxygen where it's needed. Another thing, it increases once the carbon monoxide is bound to hemoglobin, it increases actually affinity of oxygen for hemoglobin. What that does, when you increase the affinity, it means hemoglobin is tightly bound to the oxygen. So decrease in partial pressure of oxygen in tissues actually doesn't allow oxygen to dissociate from the hemoglobin. So two ways. One is you're taking away, carbon monoxide is going to take away majority of the hemoglobin, not available to deliver oxygen. And also those who are bind to that, their affinity has gone so high for oxygen that oxygen won't even dissociate. So you're not able to deliver oxygen to the tissues. That's what this graph is about. It can happen, carbon monoxide toxicity, the inhalation and ingestion of methylene chloride found in the paint strippers. I don't know, I've never used that. Carbon monoxide rapidly binds to hemoglobin to produce carboxyhemoglobin. And that's where it talks about the binding affinity of carbon monoxide, which is very high for hemoglobin compared to the oxygen, almost 230 to 270 times. Thus even low concentration of carbon monoxide will be able to bind and produce significant level of carboxyhemoglobin. And bound carbon monoxide increases hemoglobin affinity for oxygen at the other oxygen binding site. And with that increase in affinity, it prevents unloading of oxygen in the tissues, further reducing oxygen delivery. And one of the most prominent sign of a symptom of carbon monoxide poisoning is cherry red skin color. This is one of the most important because you have highly oxygenated blood, and that causes discoloration of the skin. And that will be one thing that you want to look for if someone has a carbon monoxide poisoning. Other symptoms can cause hypoxia, including headache and other listed ones here. And higher exposure actually can lead to seizures, coma, and even death. How do you treat that? Treatment include prompt removal from the source of carbon monoxide and 100% oxygen. So that's the treatment, using the face mask or endotracheal tube. So 100% oxygen is the treatment. Other one is the cyanide poisoning. And this again, kind of we talked about a little bit about the cyanide poisoning as a side effect of one of the drugs we discussed in the hypertension and heart failure. Do you guys remember that drug? And that was also the test question, actually. It could have a cyanide poisoning as a side effect. Sodium nitroprusside, that has the side effect as a cyanide poisoning. So what happens here, what it does when you have excess of the cyanide, it actually inactivates one of the enzymes called cytochrome A3 or complex 4, which part of the oxidative phosphorylation process, also known as cellular respiration. And if you go back all the way to our biochemistry lecture, we talked about those cytochrome when we were talking about the TCA and electron transport chain. There you'll find cytochrome A3 and the role of complex 4. So what happens when you have a cyanide poisoning, it inhibits this cytochrome A3. Even death can occur quickly because you don't have any more oxidative phosphorylation happening. You don't have any energy source, which is ATP, that is produced through the process of oxidative phosphorylation. So that would be the serious consequence. even though those who survive may suffer from Parkinson's, ataxia, optical atrophy, and other neurologic disorders. Common symptoms: headache, anxiety, confusion, and others listed here. How do you treat it? The antidote is hydroxycobalamin, which is vitamin B12A. You give that IV to bind to cyanide and then produces cyanocobalamin, which can be easily eliminated from your body. And that's the treatment that is approved. And if you look at the link at the bottom, if you're interested in learning more about that, that's a good source where you can find more information about this. And there's some other piece of information at the bottom. The induction of hemoglobin with sodium nitrite should be avoided unless the carboxyhemoglobin concentration is less than 10% in patients with the smoke inhalation and cyanide toxicity. Iron, that is a common, believe it or not, this is one of the most common overdose you see, because iron is a part of the supplement, which a lot of people take iron as a supplement, and also it is part of the other supplements as well, dietary supplements. So that could be one source of accidental ingestion. Yes, both of them could cause, exactly, both carbon monoxide and cyanide can cause that. But in carbon monoxide is the one thing you want to look for is the cherry red skin. In cyanide poisoning, there are the other symptoms as well. Someone was asking that question. Okay. So in case of iron, you can actually detect this on abdominal radiograph if there's enough concentration of elemental iron in someone's body. Toxic effect can occur even with the ingestion of as little as 20 milligram per kilogram of elemental iron, and doses of 60 milligram per kilogram may be lethal. Symptoms based on the level of iron overdose or toxicity. If the serum iron level is anywhere between 500 to 1000, it can cause a shock, and a level higher than 1000 can cause death. Normally, you're going to see nausea, vomiting, abdominal pain, and depends on how much iron is ingested, the patient may experience a latent period before you see the symptoms. Treatment, you use this compound called defroxamine, which is an iron-specific chelator. Because iron has a positive charge, so defroxamine uses that to bind with free iron, creating ferroxamine, which is excreted in urine. Hypotension can happen, so when you're giving this defroxamine, make sure that you don't give it as a rapid intravenous bolus. In this case, you'll experience hypotension. So it's always administered as a continuous infusion. So that's the caution you have to take when you're trying to treat the iron toxicity. So next one is lead. And again, lead is been in news at least like 3-4 years before. There was a big time in news because of the Flint water situation. There was a lot of lead exposure happened because of the pipeline. Lead started leaching out from this pipeline. They switched the source of water, and the water they were using was actually through the pipeline. It was taking the lead out of those pipeline and going into the individual's water supply. So that's where the lead was in use a lot. And if you look at the amount of lead, the toxicity is actually associated with how much lead concentration in the blood. And if you look at that, it's actually really low. It's a deciliter, and this pico, a nanogram per deciliter. This is a really low level, but it's still higher the levels of lead gets into body, the severe the symptoms you're going to see in there. Especially in children, it has a more serious consequences than in the adult. And it starts with even the low dose placenta transfer, so it gets into the fetus, it decreases IQ, hearing, growth, developmental toxicity. Anytime you start going more than 10, you start experiencing developmental toxicity. and go further higher, you're going to get the erythrocyte protoporphyrin, and vitamin D metabolism will start reducing. You can't use vitamin D. Even go more higher, you'll start experiencing nerve conduction velocity, will start slowing down. Even more higher, vitamin D metabolism will be severely affected, and keep going up, and you're going to start experiencing like even hemoglobin synthesis will start going down. And eventually it gets to the nephropathy, encephalopathy, and eventually death. So it's a serious situation with the lead exposure, and a very minimal amount of lead can cause serious effect. Here is some information about adults usually absorb 10% of the ingested lead, whereas the children can absorb up to 40%. So that's what the toxicity actually more pronounced in children, because even if you ingested, only 10% makes it to your body. Actually, in children, it's 40%. Inorganic form of lead are initially distributed to soft tissues and more slowly distribute to the bone, teeth, and hair. Lead impairs bone formation, causes increased calcium deposition in long bones. You can see that on X-ray. Lead has an apparent blood half-life of about 1 to 2 months, so it doesn't get out from your body that fast. And if it makes it to the bones, it's going to stay in your body for next 20 to 30 years. So this is a serious toxicity. Symptoms, all of those are listed here. We saw some of those in the previous slide. But early symptoms can include discomfort and constipation, occasionally diarrhea, and higher exposure can produce painful intestinal spasms. CNS effects includes headache, confusion, clumsiness, insomnia, fatigue, and impaired concentration. Blood levels anywhere from 5 to 20 microgram per deciliter have been shown to reduce IQ in the absence of other symptoms. And there are a host of the other effect on the red blood cells as well. In adults, death is rare given the ability to treat lead intoxication with the chelation therapy. So it's good that we have, once you identify the lead toxicity, it's treatable and you can do the detox. And treatment include multiple chelators can be utilized actually. The one which is listed here is called Succimer, which is dimercaptosuccinic acid, or DMSA, is a treatment of choice. And if the lead levels are greater than 70 microgram per deciliter, or if you observe encephalopathy, you would like to use two different treatments called dual parenteral therapy is required. Dimercaprol, which is given IM, and then calcium disodium acetate, which is given intravenously. So these are the two treatments based on the levels of the lead. And one piece of caution, dimercaprol is actually suspended in peanut oil. So anyone who is allergic to peanuts should not be given this a drug. And finally, we have the benzodiazepine overdose. A lot of people take benzodiazepine, right? And there are two different types of benzodiazepine based on the duration of action. There you've got the long-acting one and the short-acting one. And its overdose is basically associated with the addiction. I mean, when you are taking it because you're addicted to it, that's when you will see the benzodiazepine overdose. So here I have a question for you guys. Which one do you think will be more addictive or has a chances of producing addiction, whether it's a long-acting one or short-acting one? Which one would be more harmful in terms of making you addicted to benzodiazepines? Are the long-acting ones or short-acting ones will be more addictive? How do you become addicted to something? Obviously, you have to take it repeatedly, right? You want to take it again and again and again and again. And eventually, more and more you take, less and less effect you experience. So you keep increasing the dose and the frequency of intake or administration. So with that in the background, Now, can you guess which one would be more addictive, long-acting ones or short-acting ones?
Short act.
Maybe long acting.
Anybody else? Someone was saying something else. Was that?
I
Everybody's
said
on
short
long-acting?
acting.
Hmm?
I said short acting.
Short-acting and the long-acting. What's the consensus? Short or long?
I'd say short.
You say short? Okay.
I'll say long.
You say long?
I'm saying short.
So take, okay, I mean, if we take a poll, where the most of the classes stand? Short? How many of you agree with the short?
I do. Same. I don't know how to express it.
I know. Raise your hand. there is something you can press down there. A button or sort of that says, okay, Lisa has raised her hand. For the short or long?
I'd say short acting.
Short acting. So yeah, here is the, as I was describing, the chances of addiction goes up, or anything that is a short acting means you took it and you felt good about it. For whatever reason, you're taking that. But it's very short acting. The effect disappears or effect goes away in next few hours because it's short acting, right? 1 hour, 2 hour, 3 hours. So you go back, take it again. Same thing happens. Within few hours, you lose the effect. So you keep taking it. And remember, one of the things we talked about, that all these drugs work through receptors. Benzodiazepine works through GABA receptor, right? And anytime we are talking about the drug receptor interaction, longer you take and more you take, and more frequently you take, you eventually enter into tachyphylaxis or desensitization. So effect will start going down with the same amount you're taking over the course of time. So you will go on increasing the dose and more frequently you're going to take. And that's what eventually makes you dependent on that drug. But it's a long-acting one, actually. You took it one dose and it's going to last for like whatever time, 8, 10 hours or 24, 48 hours, whatever the half-life of the drug. So you're not taking anything in between that. So the chances of you repeating that dose will be less if it is a long-acting compared to the short-acting. That's why short-acting drugs, especially the psychoactive drugs, are more addictive compared to the long-acting ones. Does that make sense to you guys? Anyone has a question on that? Okay, so if you have a benzodiazepine overdose situation, you treat with the two different medications. And actually, there is a link on the slide. If you guys look at that, there is a lot of information there. And actually, it's the CDC website, part of the CDC website. That's where I got the information. So there are two drugs you can use, buspirone and also flumazenil. And so the other one is really, flumazenil one is really easy. It's an antagonist of benzodiazepine, a GABA receptor. It binds to the GABA receptor and prevents benzodiazepine from binding to, just like we talked about naloxone in opioid treatment. Use the naloxone, which is an antagonist, it will bind to the receptor, it doesn't let the drug bind. Same with the flumazenil. It will bind to benzodiazepine receptor and won't allow benzodiazepine to bind. So that's the one way you can treat that. Other one is buspirone. Buspirone is really interesting. It's one of the anti-anxiety drug that is not benzodiazepine or doesn't belong to benzodiazepine or barbiturates class, which are mostly used for treatment of anxiety. So buspirone is one of those. It's actually a partial agonist of serotonin 1A receptor and full agonist of postsynaptic 1A receptor. So serotonin 1A receptors are expressed in different part of your brain. And the origin of serotonergic neurons in your brain is in an area called raphe nuclei. And that's where serotonin 1A receptors expressed on presynaptic neurons. So partial agonist means you're limiting the release of serotonin. And that helps with, in this case, the treatment of anxiety that develops as a result of not taking benzodiazepine. So it helps with the anxiety and doesn't make you that hungry, a craving for taking more benzodiazepine here. Because the reason you start taking benzodiazepine is because you have anxiety that is not self-control. You can't control yourself, and there is a factors that making you more anxious and goes to the point where you need the treatment. That's where you take the benzodiazepine. but then over a period of time, it becomes an addiction issue. So the buspirone is a serotonin 1 receptor partial agonist, whereas the flumazenil is actually a benzodiazepine, a GABA receptor antagonist. That's how you treat benzodiazepine overdose. And here is a list. Again, this is from your book that kind of lists a lot of different drugs here that are used for the different toxicity, the ones we didn't cover. And some of them we have already covered, like we know how you treat warfarin, which is vitamin K when you give that person. Organophosphate, we covered, nerve gases, we covered all that in autonomic lecture, atropine and pralidoxime, the drugs, opioids, everybody knows that, naloxone, we just were talking about that, hemoglobinemia, methylene blue, methanol, ethinyl glycol we talked about, it's a fomepizole, lead, these are the calcium disodium, ADTA, dimercaprol, succimer, and there's a drug for isoniazid and this mushroom, pyridoxine, and iron difuroxamine. So these are the drugs. Heparin, we already know that protamine sulfate, digitalis is very well known, this digoxin antibody. So this is what I expect you to remember from this lecture. And there are a few questions you want to go over that before we finish up. So take a shot at this one and see what do you think about that. Which substance was most likely ingested?
Iron.
Okay, good try. Anyone else?
C, ethylene glycol.
Okay, anybody else? See, this is the one I was talking about, that you have to really well aware of the symptoms of different dose. And if you go back and look at, I don't know who said ethylene glycol, but I think ethylene glycol is the right answer, because one of the things you want to look at it is hypocalcemia. If you go all the way down there, because it causes formation of calcium oxalate crystals and decrease in calcium levels, that's the sign of hypocalcemia. So ethylene glycol is the right answer. It's on the slide when you go back and review that. We'll see that hypocalcemia part there. Let's try this one. Focus on the symptoms. Read symptoms carefully and see what that reminds you of what can cause those symptoms. Nausea, vomiting, sweating.
Atropine.
Yeah.
Atropine, because all these are cholinergic excess, symptoms of cholinergic excess. And the way you can treat it is prevent acetylcholine from binding to the receptor, and that's where atropine is a muscarinic antagonist, and that's why atropine is the right answer. The last one, let's give this one a shot. This was pretty obvious though. This one you guys will get it.
Carbon monoxide.
There you go, carbon monoxide. That's it. So that's our lecture for today. Is anybody has any question on that? I think we took pretty good amount of time. It's almost 2:40. So without any break, we finished in 1 hour 40 minutes. If you don't have any question, feel free to email me if something comes up. Otherwise, we'll see you guys a week after next. Thanks for joining on Zoom.
Thank you.
Thank you.
Take care. Bye.
Thank you.